Is that working for everybody, more or less?
Looks great.
Okay, perfect.
Ask me the link.
Okay, I'm gonna have to start now.
Yeah, let me share that.
Okay. And I apologize in advance because I think that as is often the case on the right-hand side of the Zoom screen is sort of blocked by the people's photos, but in any case, thank you so much on behalf of me and Adolphe for having us here today for the Global Health Grand Rounds. We're really, really happy to be a part of it. So today I'm going to start by giving
You might be able to minimize the people there. There's usually a little thing you can minimize it to one little thing.
Is that
Yeah,
how'd that go?
yeah, it's a lot better.
Oh, perfect. Thank you. Thank you for that tip. That's my first time hearing that tip and it works well. Okay, so I'll introduce myself. I'm Susannah Leisher. I'm an epidemiologist and I'm the co-director of the Utah Stillbirth Center of Excellence at the U. And I'm going to start today by giving an overview of the Rainbow Clinic model and rationale. And then Adolphe is going to present the rationale, the status, and plans for improved perinatal loss care in Rwanda, including a Rainbow Clinic. And then we'll end with some time for Q&A. I'd like to acknowledge that the land on which we're meeting to give this talk, which is named for the Ute tribe, is the traditional and ancestral homelands of the Shoshone, Paiute, Goshute, and Ute tribes, and it's a crossroads for Indigenous peoples. We'd also want to provide a content warning that we will be discussing stillbirth and other types of pregnancy loss. So I think it's always good, even with a medical audience, to ensure that we know what we're talking about. One of the many outcomes of conception is stillbirth, which is the death of a baby before or during birth. So either an antepartum or an intrapartum stillbirth. The dividing line between stillbirth and miscarriage is fuzzy and based on different gestational age thresholds depending on the country. But in the United States, the national line is 20 completed gestational weeks. The dividing line between stillbirth and neonatal death is much clearer, essentially whether there was a heartbeat or breath after birth. But even here, there's much misclassification, even in the landmark U.S. national study of stillbirth, led by the U together with other sites, where several stillbirths were misclassified as neonatal deaths, as well as the reverse. So why should we care about stillbirth? For me, it's personal. I'm the mother of Wilder Daniel, my first child, who was stillborn at full term, 38 and a half weeks, after an uneventful pregnancy. That's me, happily pregnant on the left, and me again, holding Wilder in shock after his birth. Despite an autopsy and multiple tests, no cause was ever found for his death, and he's really the reason I'm here today. But stillbirth is important on a global scale. Counting only stillbirths from 28 completed gestational weeks on, which has been the norm for global statistics, stillbirths comprise 26% of the entire global burden of deaths of mothers, babies, and children under 5. Recent global estimates that include stillbirths from 22 weeks on would significantly increase stillbirths' share of global maternal and child deaths. Nearly 2 million babies are stillborn at 28 or more weeks each year, with huge national variation in stillbirth rates, from Iceland at less than 2 to Afghanistan at more than 26 per 1,000 total births. Nearly half occurred during the process of labor and delivery. What's often surprising to U.S. audiences is how bad the situation is here as well. Half of all U.S. deaths to newborns and infants are stillbirths, roughly evenly divided between early stillbirths at 20 to 27 weeks and late stillbirths from 28 weeks on. There are twice as many stillbirths in the United States as there are deaths to children aged 1 to 14 from all causes combined. The U.S. compares poorly on the global stage as well, with a stillbirth rate that's higher than 27 other countries and an annual rate of reduction that's slower than 151 other countries. As is the case globally, there is wide variation in stillbirth rates between states and territories in the U.S., ranging up to more than 13 stillbirths per 1,000 total births in Guam and over 9 in Mississippi. And unfortunately, it should be no surprise that there is also great racial disparity in stillbirth rates in the U.S., with stillbirth rates in Black and Pacific Islander families that are nearly twice as high as in white families. Another challenging feature of the stillbirth burden, which I know about from personal experience, is the very high proportion of stillbirths that are unexplained. In the US, over 30% of stillbirths have no cause found, and these data only include states for which the proportion unexplained is less than 50%, so it's an underestimate. Even in the Stillbirth Collaborative Research Network, that landmark US study conducted at the U together with other universities that had gold standard investigation, nearly 1/4 of stillbirths had no probable or even possible cause identified. Hence, the stillbirth burden extends beyond mortality to include a paucity of research that might help to identify effective prevention strategies. And after stillbirth happens, there are additional challenges that add to that global public health burden. Stillbirth often brings unexpected additional financial costs, including time off work for bereavement, as well as mental illness, with one estimate at more than 4 million women suffering from depression each year as a result of stillbirth. Caregivers also suffer from the trauma of this experience, and for women who become pregnant again after stillbirth, these emotional and psychological stressors are exacerbated. There's also an increased risk of stillbirth recurrence, with studies putting this at 2 to 5 times increased risk in a second pregnancy following a stillbirth in the first pregnancy. As with stillbirth generally, there's great racial disparity, with one study finding a 3-fold increased risk of stillbirth recurrence in Black versus white families. And stillbirth also brings an increased risk of other adverse pregnancy outcomes in a subsequent pregnancy, including a nearly 3-fold increased risk of prematurity, low birth weight, and preeclampsia. So this is a very long lead up to the Rainbow Clinic model. A Rainbow Clinic specializes in pregnancy after loss, including stillbirth. Rainbow Clinics were established over a decade ago at the University of Manchester in the UK by Dr. Alex Hazel, and now they number more than 30 clinics across the UK, which have provided care to more than 1,500 women and their families. The UK Rainbow Clinics score very highly in patient experience, and unpublished data also suggest improved birth outcomes, including a lower than expected stillbirth recurrence rate. There are 10 core principles for what it takes to be a Rainbow Clinic. And essentially, Rainbows must provide care to all those pregnant again after stillbirth, newborn death, or termination for fetal anomaly. They must provide care at the same level of quality, regardless of insurance status, ensure the care team is multidisciplinary and has undergone specialized training, follow a standard protocol, including reviewing results of all investigations into the cause of the prior loss, provide at a minimum signposting to mental health care, ensure that care is tailored to the individual's needs, and agree to contribute to joint research together with other Rainbow Clinics. The third Rainbow Clinic in the United States is the Utah Pregnancy After Loss Clinic at the U, known as UPAL. UPAL provides care beyond the minimum required by Rainbow Clinics, also including pregnancy after placental disorders or traumatic birth, termination for any reason, and preterm birth. UPAL patients have access to additional appointments as well as bedside ultrasounds, and clinicians provide regular mental health screenings, including for depression, anxiety, and PTSD, as well as fast referrals to a mental health care professional as needed. Since December, we've also provided peer support through our program manager for Parent Voice, Stacy Fletcher, who is herself the mother of a stillborn son, Benjamin. Stacy is embedded at UPAL once a week to provide on-site peer support as well as virtual support on other clinic days, and she keeps the MFMs and other clinic staff updated through the patient charts. Peer support also includes L&D tours that are UPAL only, plus sharing information on other resources for in-person and virtual support. And another key aspect of UPAL is the soft handoff that our peer support provides between patients and our research team as a means to increase parent participation in our research programs for stillbirth, placenta accreta, and related conditions. All UPAL staff must undergo specialized training as per the Rainbow Clinic core principles. Key required features of the training include having it delivered by a parent and clinical educator team, covering both medical and emotional aspects of care, providing training in person if possible, and always in a mode and manner that is respectful of trainees and their time, with feedback sought on a continual basis for quality improvement. Training modules cover stillbirth statistics, the effects of pregnancy loss on parents, including the possibility for anxiety, depression, and PTSD, clinic protocols, and resources for staff support, with parent perspective infused throughout. Training sessions are adapted for specific trainee groups ranging from researchers to sonographers. Having the training co-led by a parent is really important as a way to break down barriers between patients and clinicians, helping to ensure the high quality of patient care at UPAL. Since the launch of UPAL last May, we've provided care for more than 100 patients, including consults and new PAL patients, with more than 170 return PAL patients. Since last December, we've also provided peer support to over 50 patients, and our trainer team has trained more than 200 staff and clinicians. Trainee feedback has been really positive, with trainees emphasizing how helpful it was to hear the story of an actual lost parent. One trainee said, "I don't think any other perspective would have been as effective." UPAL is a founding member of the U.S. Pregnancy After Loss Network. We have members in 6 states, including the first Rainbow Clinic in the USA at Mount Sinai in New York.
Would you like a fountain or house-made drink today?
No, thank you.
I wonder if
You ever
somebody
have
could
any
really,
with after it's ready to scan?
No.
No, or
I think somebody's
okay, you're told
needs to
it's
mute
14.
themselves. Awesome. Okay. So Mount Sinai's Rainbow Clinic launched in 2022 and has seen nearly 200 patients since then. Outcomes in the 137 pregnancies that have delivered at Mount Sinai have been very positive, with a mean gestational age of 37 weeks, a mean birth weight of nearly 3,000 grams, and no recurrent stillbirths. And importantly, just as with the Rainbow Clinics in the UK, patient feedback has been hugely positive. Patients have commented on the compassion and understanding of clinic staff about their need for extra visits, where patient anxieties are understood and not dismissed. One patient said, "I'm not sure how I would have emotionally made it this far in my pregnancy if it wasn't for that compassion and handholding." The U.S. Rainbow Clinics are proud members of the International Rainbow Clinic Network, which was formally established earlier this year. The aims of the Rainbow Clinic are to ensure medical and emotional support, to improve patient experience and birth outcomes, and to contribute to research. There's growing interest in Rainbow Clinics internationally. In addition to the founders in the UK, the US PAL network in the United States includes Mount Sinai, Columbia University, and UPAL, as well as 6 clinics in our 2025 cohort, and 2 parent organizations, at least one of which is on the call today. That's the Iris Fund and the Natalie Foundation. In addition, colleagues in Australia, the Netherlands, and Ireland are at varying stages of developing their own versions of the Rainbow Clinic model, informally collaborating with the international network. A 6th country with great interest in the Rainbow Clinic network is Rwanda, and I'm pleased to hand over the remainder of our presentation to Dr. Adolphe Karegeya to discuss this further. Dr. Karegeya is the clinical director at Karegeya Specialized Clinic of the nonprofit Réseau de Femmes. He's a consultant obstetrician at the Polyclinique de l'Étoile and former clinical director of Kasiru Hospital of Kigali, Rwanda. He's also a former Women's Health Equity Fellow at the U and a member of the Stillbirth Advocacy Working Group. Dr. Karegeya, over to you.
Okay, thank you, Zan, and thank you for having me here today and this opportunity to present. As you have already presented me, I would like just to say my motivation to focus on perinatal loss services in Rwanda. This deeply rooted in gap I have witnessed in care provided to families experiencing stillbirth and neonatal death. In many low-resource settings, these less remain hidden behind cultural silence and stigma. Family grief alone, with limited emotional support and no structured guidance through future pregnancies. As clinicians, we are often inequipped to meet these needs, not due to lack of compassion, but due to lack of system and training that recognize and respond to the depth of perinatal grief. During my MSI capstone project, I had the privilege of working under mentorship of Dr. Brian and Prof. Suda, who is MSCI Global Health Innovation Technology Director, and under Susannah Leisher, whom I have privilege to work under her guidance. And she's a global leader and co-founder of International Stillbirth Alliance. Her vision and advocacy opened my eyes to transformative power of respectful bereavement care and multidisciplinary support for families after loss. This experience was a turning point. It inspired me to move beyond research and toward building real, lasting change. Today, I'm proud to share that I'm working to establish Rwanda's first rainbow clinic, a comprehensive model of care of family navigating pregnancy after loss. This clinic, as Zan has presented, will work to holistic approach, psychologists, clinicians, and other way to support patients. As you can see on our presentation, just before talking anything, I would just present Rwanda, which is a small landlocked country in East Africa with a population over about 13.5 million. And it is recognized for its resilience, innovation, and strong commitment to health equity. The country has significantly strengthened its health care system, which achieving over 70% reduction of maternal mortality, enrolling more than 90% of population in community-based health insurance. Despite Rwanda's remarkable progress in maternal and child health, stillbirth and perinatal loss remain critical gap in the health system. Yes. As Rwanda, you can see on our neonatal mortality rate, which was 20 per 1,000 live birth. This is the data of 2022. Stillbirths are often underreported due to limited surveillance and lack national policy and classification system. Yes. This is data which has been done in one of the massacre hospital. It is in Kigali city, as you can see on the map. This was done where 804,011 deliveries were recorded in 1 year, 2022, and there were stillbirths of 128 and 174 were early neonatal death. These were the deaths occur only within 7 days of life. This result of perinatal loss, it is a very high of 35.8 per 1,000 total births. This is more than national data. And as you can see, if the data of one of the hospital, which is in Kigali, where they have gynecologists and other resources more than other remote settings, it's really something we need to discuss, as it's a high burden in both urban and rural settings. The same study which has been done at the Massacre Hospital revealed that the maternal infection, especially sepsis, were higher at 20%, and prematurity were the cause of death to 20.5%, and birth asphyxia and congenital anomalies were other cause of death. Yes. This is another data of stillbirth which has been done at Kachi Hospital, which is one of the most leading maternal hospital. where over 68 stillbirth, which was recorded in 1 year, 42% the cause were not really known. And 11% of them, they were missed fetal heart rate during labor. This also highlights the need to intrapartum monitoring. And the cause of stillbirth is, they are not really not known. This also show that we might look on the cause, either to investigate through placenta biopsy or autopsy for stillborn. We can investigate. This is another gap still on the reason of stillbirth. The same other study which has been done in 3 public hospitals. This is data from my colleague Thomas, who is a gynecologist, have also revealed 48.3% the cause were not known. So this is another gap where we should focus on it and look how we can tackle the problem of stillbirth. But maternal risk factor such as hypertension, such as diabetic, premature rupture of membrane, which goes to infection as well, or uterine rupture, were also seen to the level of 45%. Yes. In our context, health system, 90% more than 90% births occur at health facilities. However, most delivery occur in rural area where our health system goes from health post to health center, transfer from the health center to district hospital, and from district hospital teaching level hospital or tertiary level. Those are hierarchy of health system, but most of deliveries are also you can get delivery from those health post, health centers where there is not enough skilled professional like medical doctors who can perform C-section, or gynecologists who are not enough to go to the level of health post or health center. You can get gynecology to the district hospitals, but not even the hospital, all hospital to national level have the gynecologist. The number are still limited. As challenge and gap we have for this is lack of national stillbirth tracking system, which don't have, and limited mental health support for grieving families, and stigma and silence around pregnancy loss. Because if pregnancy was to early loss, miscarriages, some with culture, they don't talk to this to neighbors. This also is still issue which can affect, or which affect psychologically the families not to grieve because of this loss. But later on, you will still find the impact of that not to be recognized. There's also shortage of trained providers in perinatal of bereavement care, and there is still birth rate is still very high in our context, but we don't have enough data for to the national level to have really this, as we don't have a national registry for stillbirth. There is also weak implementation on perinatal death audits, and there is no standardized bereavement care protocol. Yes. Yeah. This is slides of training which have been done on bereavement care at Kachiru and Muhima, and these have recognized critical gap in stillbirth care, particularly in intrapartum monitoring and bereavement support. And there is a growing commitment of improving care delivery through better documentation and early detection of fetal heart rates during labor monitoring, and enhancement mental health support for grieving families. This is underscore the need of holistic approach on stillbirth prevention and care. As you can see, majority of trainees have recognized that it will be an improvement on improvement on from the facilities how those problems are handled on. Yes. As you can see, before training, there were a significant gap in providing compassionate care for families experiencing perinatal loss, particularly lack of, there was no training, of course, and also particularly the bereavement support and effective communication and intrapartum monitoring. That was lacking before training, but after training also, the trainee got skills on active listening, counseling technique, and culturally sensitive care. How this also can be improved. If you have deep counseling of mother who had stillbirth, how they can listen to them, how they can talk to them. This has been also proven with knowledge and skill gained from during that training. As you can see on this slide, what were the most beneficial to trainees? They were in various aspects, but stillbirth management was the most, and effective communication, how we can communicate, because your communication from health providers still affect also the family or the woman during the time she got this problem. And something which were also mentioned during that training is refresher training. This training would be continuous training and mentorship to support this, and if there should be a clear protocol and equipment, a clear protocol to guide and to help providers. That was also mentioned during the training. The other support needed to improve care and families experiencing stillbirth were, as I said, refresher training, mental health support for providers, and standardized protocol, how we can tackle this problem, how we can handle this issue, and peer support mentorship. That was also another mentioned point. So for our vision and goal, when we want to establish Rwanda Rainbow Clinic, is to transform perinatal loss care through holistic, compassionate, and dignified support services in Rwanda. This holistic approach will involve psychologists, clinicians to support families who have lost their owns. And we want to raise awareness and reduce stigma around the perinatal loss and provide structural care pathway for grieving families, and to build providers' capacity through training, as we have already initiated. This training will be continuous training, not only to one facility, to be training which can go through other facilities and reach many providers. And to establish a sustainable model with Rwanda's health system, and to reduce stillbirth rate in Rwanda. That is one of our goals, just to establish Rwanda Rainbow Clinic model. Yes, as you have seen, they have been something which already has started. It's just not a presentation, but we have already engaged with some stakeholders like hospitals at Muhima, Kachiru, and RMH and Polyclinique de l'Étoile, and also Réseau des Femmes, which is a non-organization which has a specialized clinic, and RSOG. Those are stakeholders which we have already started how to work together. And some of the clinic, such clinic Étoile and Karame, we have signed a memorandum of understanding how we can support these projects, providing logistic support, ultrasound, some lab investigation, especially at Karame, where patient who will be followed for this project can have free access of exams and clinical support in context of Rainbow Clinic package as it has been presented by Zan and in our context as well. Yes. Those are some of my colleagues at Réseau des Femmes, where currently I'm working, and I'm with that NGO. There are some women you can see. One of them has also history of stillbirth. She's now lucky pregnant again. We are following up for her pregnancy. But as you know, women who had a previous history of stillbirth with risk of recurrent pregnancy loss, they are already psychologically affected. So that's when when I was scanning her, she told me, "Can you see if my baby is breathing well? Can you see if heartbeat is well? Okay. Can you see if my baby has all normal anatomy scan without any anomaly?" So those are questions, and really patient need support from our sides, from clinicians. And when you are doing clinical work, also you have to work on approach which is holistically and which is also supportive to families. Yes, we are now working on Rwanda Perinatal Loss Services website, which is under construction. This is, sorry, yes, this is, as I said, that is under construction website, but we'll also have the software which we can have communication with patients and get online consultation with them. Yes. As way forward, we also have a plan for implementation of modified international stillbirth alliance classification in hospitals and train health workers in perinatal bereavement care. And as we said, also piloting this model of Rainbow Clinic in Kigali. And we also plan to start awareness campaign to reduce stigma around stillbirth. This, as you can see, this is one of my picture when I had the privilege to talk about stillbirth at national television. This also is part of this awareness talk to public. In future, also want to have a national guideline for stillbirth prevention and management, and a national register and reporting system to integrate a mental health into maternal care, which would be a holistic approach, as I said, and scale up of this practice in clinical across the country to establish a perinatal loss advocacy network. Our partners is, of course, Ministry of Health can't work without support from Ministry of Health and our body Society of Rwanda Society of Obstetrics and Gynecology and University of Rwanda, University of Utah Center of Excellence for Stillbirth, which currently we are also already working with them, and Global Health Innovation Technology at University of Utah, and Women Health Equity program at University of Utah, and international research and academic partners and local NGO as Réseau des Femmes. Those are partners whom really we thank how some of them have already contributed to this embryonic phase of our project, but hoping that will be matured and get impact to the community. We also, of course, want to have funding and training for more providers. As we can say, anything needs also funding. And we also want to break the silence around perinatal loss and collaborate across sectors and disciplines and to come up to long-term change for women and families in Rwanda. And we want to establish a national perinatal audit and classification system and train providers on bereavement care as it has already started, but this will be continuous training and program to providers. And want to expand research and policy advocacy once funds are available to do so. Thank you very much.
Okay, so that's our presentation. We're sitting together in the same room. We hope that it was interesting or useful, and we're here and happy to answer any questions, or we'd love to hear anybody's comments or observations. Do you want to sit? Which is,
yeah, it's okay.
We're right here.
Yes.
This is Ray Price. I thought that was a fantastic presentation. It's exciting to see how to address a real serious problem. I lost a 2-month-old baby, so not quite in the stillbirth, but 2 months old.
Right.
And so it is, I think, a very important. Actually, today is a 5-year anniversary of my 36-year-old daughter that passed away. So there are things that that really are quite important. And I think, like you mentioned, just barely beginning to see some of that here in the U.S. and even less so in the countries that we work in. And so I commend you to the work that you're doing there. I think it's exciting.
Thank you.
Thank you.
I guess I have one question. You talked about decreasing the stillbirth rate with doing these kind of programs. Why? Do you have, I mean, you can certainly surmise some different things, but why would you expect the
Right.
stillbirth rate to decrease? What do you think the mechanism is?
Yeah, I mean, that's a really good question. Do you want
Yeah. Okay. Thank you, Doctor. This is a very nice question. And first of all, why it's a question which is somehow difficult to say, but with support to each of the providers and work on the risk factors, that will really definitely help to reduce stillbirth. If women had previous history of stillbirth, has any maternal risk factors such as diabetes, such as hypertension, such as any underlying condition during pregnancy, once she gets care which is appropriate and specific, special care, that would probably reduce stillbirth and policy as well. So those are some of mechanisms which can be established and look on it. As I said, during our in our system, health system, you normally found transfer process from low level to high level, but even from the low level, the patient can be seen and transfer to get special care where it can get maybe a gynecologist and have plan of delivery ahead of time if she has a high risk of having a stillbirth. I don't know if I tried to say what can be done. Maybe.
I mean, I would agree, and but I am not a medical person, so but I would agree that, you know, the increased attention paid to women who are at higher risk in and of itself is going to, you know, kind of get at multiple mechanisms, whether it, you know, paying attention to women's risk factors, they're, you know, they're as well as increasing perhaps the demand for that care. Women are perhaps more likely to go in for additional monitoring if they know that the setting is sort of receptive to their prior loss. So that could not only be an increase in the supply of higher quality care, but also demand for it. But that's just hypothetical. I don't know if anybody else who's an MD on the call would like to weigh in on that, or have any other questions or comments.
Yeah.
We have a question in the chat. Sorry. Let's see, what could be feasible policy and programmatic interventions to address the issue? Yeah, okay. So I have answers and so do you. What are some actual policy interventions that you would like to see in Rwanda and that I would like to see in the US that can help to address the stillbirth challenge?
Yeah, thank you very much. This is a question raised by one of my colleagues who is in Rwanda, Dr. Polyfield. Thank you very much for your question, really. And as you know, the policy in Rwanda about health policy is receptive to any innovation, any changes that can give better outcome both for maternal and child. The Rwanda, they are among the best country, which I can say work on that. But the issue is that the resources, the means, there is a way to screen high-risk pregnancies. But some of the investigation we don't have, like patients who have recurrent pregnancy losses, recurrent miscarriages, the patient whom we might think about antiphospholipid antibody syndromes. We don't have that means of investigate them. But those policies, as you said, they can, if there is means to provide those means to investigate, those are a high-risk patient whom maybe intervention can be done ahead of time. Those are patients who can have free access ahead of time to be seen by gynecologists and have care plan and delivery ahead of time. I think policies and means goes hand on.
I mean, I would agree. I would also add, though, that there are, you know, plenty of potential policy interventions at every level. And in the state of Utah, for example, one of the things that the Utah Stillbirth Center of Excellence is working on together with the Utah Department of Health and Human Services is to see if we can amend the state legislation to allow updating fetal death certificates retrospectively after the results of autopsy and other investigations are available, in case a cause of death can be identified, currently it's more difficult to amend those fetal death certificates. And the problem there is that this has a very negative effect on the quality of data about cause of death. And you saw both from the Rwanda context and the US context, we have huge proportions of unexplained stillbirths from 25 to 40 to 50%.
Yes.
So there are policy interventions that can help in terms of improving data quality as well.
Yeah.
Just to take one example. I see there's another question here from Katie. How are we working with midwives in your respective settings?
Yes.
I'm going to answer that first. This
Yes.
one.
So,
How are you working with midwives in Rwanda?
okay. Midwife in Rwanda, there are many than doctors and gynecologists. We work together are the one who monitor labor, and especially when you have someone with history of stillbirth, I think the midwife, they are the one to know that this is a patient who needs special attention and special monitoring. As you have seen on other data, we have 11% of the patient who had missed the fetal heart rate tracing during labor. That is something we need also to discuss and tackle about the labor monitoring. But the midwife are the one monitoring labor, are the one delivering. Most of gynecologists or GP comes just for most complicated cases. But midwife, we work together, and they're very nice people, if I can say that. Yeah. I don't know if I try to. Yes.
I have two thoughts also to add. One is that yesterday, Adolphe and I were talking a little bit about or today about the training piece, the bereavement training. And we were talking about how to get that training beyond the obstetricians, gynecologists in Kigali, out into the rural areas, the district hospitals. And one thing we were talking about is the language and translation of training materials, and probably that, you know, to reach, for example, midwives and provide them with bereavement care training.
Yeah.
One of the things that would be required, which would cost money, is, you know, sort of translation into Rwanda.
Yes.
Am I right?
Mm.
Language. So that would be perhaps a barrier. I also wanted to add from the Utah side, Utah Stillbirth Center of Excellence, we're really lucky that we are starting to do better at integrating midwives into the work that we're doing. One example is our Improve USA workshop. It's a half-day clinical training on improving care at the time of stillbirth. We provided that workshop last October, and we're really excited that one of the core team to help us get that clinical training workshop out and across the US is a midwife from the U. So we're trying to do better at integrating multiple specialties. Let's see, what else? So here's a question from one of your colleagues.
Mm.
Considering the risk of stillbirth, what is your thinking about the baby show habits nowadays? I'm not sure.
Considering the risk of stillbirth?
It's from Diomed.
Okay, I didn't hear well the question.
I don't know. This is it. Maybe you can ask Diomed.
Yeah,
Are you there?
Hello, Prof. Diomed. I'm not
Good to
catching
see you, all of you guys. I don't want to show my face because I'm ready to sleep. So,
Sorry.
you know, Dr. Adolphe, very good. Thanks a lot. It's a very nice, yes, it's a baby shower, not baby shower. I was talking about the ritual of making some kind of,
Oh, yes.
when we are expecting a baby, and
Yes.
there are a lot of stories in Africa. So what will you say? What do you think?
Oh, okay. Thank you very much, Prof. The baby shower, this is something which is recently coming to our settings where women can feel happy and have a party before delivering during pregnancy, and maybe we don't know outcome. Maybe the outcome which can be worse, but while this party and celebration happened already. This I don't have really how to say comment, because if someone is pregnant, that is the time she feels mostly happy time. She's going to expect to have baby. I can't compromise saying this is something they don't have to do, but I don't know.
So,
Any comment from
mean,
colleagues?
Yeah, as a stillbirth parent, and I would say, one of the things we are trying to do, yeah, right, it probably did come from the US, or somewhere. We're trying to better bring in the voices of stillbirth parents to help to design our training, our peer support, even our research, to integrate their voices, their concerns, their advice, their experience. And so, Dr. Diamed, I would say that, that's a question that you can pose to your stillbirth parents in Rwanda.
Yeah.
And that's one of the reasons it's so important to have them as colleagues to call upon and ask what their advice and thoughts are, perhaps. I do see that we just have a few minutes left, and in the hour, I don't know if others have questions or comments they would like to raise.
This was great, you guys. Thanks so much for sharing all of this awesome work. I just wanted to ask, of all of the different domains that you covered, which was extremely comprehensive and relevant, all of those different needs are really there in Rwanda. I'm curious what you think is the priority for the most immediate next step of, bereavement and advocacy and clinical care. And it's kind of a theoretical question because you can tackle more than one thing at a time, but I'm curious what you each would rank as the top thing to get next.
Okay, thank you, Patrick. For me, if I respond by 1, 2, 3, I would say clinical care would be the first.
Clinical care.
Yes. Advocacy as well. Bereavement care, because those are, I don't know how I can enumerate from one to another, but all are very important and has to go at the same time. But I'm saying this maybe to respond about how I can say 1, 2, 3, but none has to be left behind.
Yeah, I mean, of course you're right that it's the right thing to prioritize, and yet you're right. It's all important. We're very lucky at the University of Utah that we have got this perfect storm of, the opportunity to provide clinical care and do excellent research and carry out advocacy and look at the bereavement side as well. And really, they all feed off each other. They're all interlinked. They're not separate endeavors. And so, it's a really tough question. We say yes, yes, yes a lot when people, suggest new
Yes,
initiatives.
and yeah.
Yeah, yes, and so that's really tough.
Yeah, there is a comment from Dr. Nkubito, who is our Vice President of Rwanda Society of Obstetrics and Gynecology. Thank you for being there also. You asked about during the post-stillbirth management, if you think about some medical legal issue that can be raised up at the period. For sure, we didn't think about this, but as you are there as vice president of our society, we need still to have to talk each point as far as we are committed to work together. And yes.
I would say just in this last minute that in terms of the legal side of, stillbirth management, that definitely sometimes that happens, that there's a legal aspect to this. And I would say that one of our colleagues in the Netherlands, Dr. J.J. Erwick, who's recently retired as a very senior obstetrician, he has great expertise in perinatal audit at the national level and in developing ways of discussing stillbirth cases that sort of grapple with these challenges and try to encourage the ability to be open about the potential causes and maybe failings of, the medical side or the medical system, but still trying to find answers and trying to also bring parents into that discussion from the beginning so that there is greater trust on both sides. So it's not an easy question. It's a very difficult question, but there are places where there's been a lot of work on that and some models that we can follow. So
yeah,
we have to stop.
but also as we are think about doing research in future when they found a law, we can also think about how we do a cause of stillbirth, also using biopsy of placenta and autopsy of the stillborn, if that permit to know exactly what is the cause of stillbirth. Those are, we have seen that there is a gap on to detect the cause, but those are issues we can also discuss. Thank you very much not to take much time.
No, I know the hour is up, but I think Liz, we need to stop. Is that correct? So
Yeah, unfortunately.
Yeah, I would just say that we would both love to answer more questions or have further conversations. We're both passionate about what we do, and we have tons of collaboration coming up and all kinds of wonderful initiatives. So please do reach out, I guess through Liz, if anybody's interested in learning more. And thank you so much for joining today. And thank you to Liz and the organizing team for giving us this opportunity.
Yeah, thank you very much.
Yeah. Take care.